So 3 things. One, now we have the video functioning, so I'm going to show that to you. That's good news. The second is, I think sometimes we get stuck with what we are comfortable with, and we just do things the certain way and never change how we do things just because of the status quo. So the presentation I will give you on virtual basophils is an example of how sometimes with the help of AI, you could actually change things and make them more useful and more practical. Virtual basophils. So I have no disclosures. These are the learning objectives. Okay, so what is a virtual cell? Virtual cells are computational models that mimic the behavior of real cells. Could be basophils, T cells, dendritic cells. They are built from real experimental data. They have the same inputs, same measurable outputs. The inputs can be stimuli, different doses, different conditions. The outputs can be markers, cytokines, activation markers, etc. They act as a digital twin of the cell. They don't replace the biology, but they extend it. They make things a lot easier, faster, reusable, makes predictions easier. So you might ask the question, so why bother build a virtual cell? So I'm going to explain that to you for something super practical. But it could be from things such as scalability, cost and speed, faster experiments, practical advantages. There could be better mechanistical insights that you could have using virtual cells. And it could help also in processes such as standardization. The question came up actually from a colleague of mine who's an allergist, immunologist in Miami. And he used our expertise and services for a specific test called the basophil activation test. The basophil activation test is a test that we measure in vitro how allergic a person is to a specific food allergen. And the premise of the test is you incubate basophils in vitro with, let's say, milk allergen, and you look at the reactivity. It's a lot more sensitive than just looking at, let's say, a blood IgE level or a skin testing to an allergen. This person was consulting to a formula company, and the question came to his mind is in that, could we use the basophil activation testing to make formula approvals in the United States faster? So at the present time, hypoallergenic infant formulas in the United States go through 2 phases of testing. The first one is you take 30 to 40 infants, you take the formula that you made, and then you take another formula called the predicate formula that's marketed, that is known to be hypoallergenic, and you do something called an open, double-blind, placebo-controlled food challenges to these infants. So you actually take allergic people, and you hope that the one that you're going to give the formula in question will hopefully not have a reaction to the formula. This is similar to how in clinical trials sometimes double-blinded placebo-controlled challenges are done to show how allergic a person is before they enter into a clinical trial. I think it's a very old-fashioned way of doing things, but it's just been done that way for many, many years, for decades. And the phase 2 of a hypoallergenic formula approval is once you've established your formula is safe, that doesn't cause an allergic reaction, you make sure the kids grow on the formula, they gain their weights, etc. So this person, he thought that maybe we could replace the phase 1 part, which is the double-blind placebo-controlled challenge, with the basophil activation test. So this will bring a 1.5-year process to maybe a couple of months. So how can we determine the allergenicity of a formula? So the foot is misspelled, it's food, to a food item. So we could either measure it by, let's say, an ELISA assay, some chemical assay, that a food is whether present or not in the formula, or we could do a functional test. There's always limitations to static tests in quantifying. It may not give you a great idea on whether they're functional or not. So the idea came, anyway, so let me first tell you what the basophil activation test. It's a functional assay The cell is a basophil. The input is a stimulus. In this case, it's the, let's say, the milk allergen, but it could be other things. It could be drugs, other allergens. And the output is you monitor a specific response that happens to this basophil once they're exposed to milk. We do that with a technique called flow cytometry, which measures cells, their size, their granularity, their surface markers. It could identify a bunch of different immune cells, basophils being one of them. It looks at the presence of the cell, their activation markers, their level of maturation. But we're going to take use of this last property that I mentioned here, which is their functional characteristics. The basophil activation test was described almost 30 years ago, more than 30 years ago, and it's been replicated, duplicated, triplicated over the years in many, many studies. And what we look at is a specific marker on the surface of the basophil that correlates with degranulation. So basophils are cells that have histamine in them, and if you're allergic to a food, the food item attaches to the IgE that's tagged to the surface of the basophil, and the basophil releases histamine from its inside to the outside, which causes the allergic reaction. As you could see in the graphs on the right, the basophil CD63 upregulation correlates very closely with histamine release. These are basophils. They have a bunch of vesicles in them, and they have histamine in it. And CD63 is a marker that's only found inside the vesicle membrane, and they become visible on the surface of the cell when the vesicle merges to the cell surface. So then you could measure it with a cell surface staining using flow cytometry, for example. And the methodology is you take blood from a person, you incubate the whole blood with different concentrations of allergens, in this case milk, and then you use flow cytometry to be able to detect if this CD63 marker is now expressed on the surface of the cell, which is an indication of degranulation. Now, what we did with this test is, as with any test, it has its flaws. It doesn't work the same way in every patient, so that you see that on the top part. So if you take, let's say, 100 patients, it's only valid in about 80% of them. The 20%, for some reason, their basophils will not degranulate properly. So even though the person might be allergic to milk, the test will read out negative. And there's reasons for that. It's been shown. There's another cell in our body called the mast cell, which also has histamine in it. And it doesn't have this flaw that the basophils have, but there's no way to test mast cells because they do not circulate in the bloodstream. Now, what we did in this scenario is, instead of using the test to understand patients, we use the test to understand the formula, the powder, or this could be any material in question. So we cherry-picked very highly responsive patients to milk. So then we got rid of that 20% non-responsive patient population, and we used them as sort of biosensors for milk. Then that 20% goes away. Then the sensitivity and specificity of the test becomes 100%. And this is because of us cherry-picking these patients. So we presented to the FDA, and they, interestingly enough, loved the idea. They said, fine, we agree, you could do it this way. So suddenly that phase 1, which takes a year and a half, became a study that can be done in just a few months. Now, but here's the problem with that issue. You still need replicates. You can't just do one person and say the patient is passed. And normally when you do comparison studies, let's say you have tube A and tube B, you're trying to compare those two together. Let's say tube B, we know what's in there, but tube A is the question. We still need dozens of patients to do that correlation. We were able to convince the agency that we don't need hundreds. We could do it in maybe 24 patients, because all we're doing with the highly reactive patient is we're just replicating each patient, so that whether we do one patient 50 times or 50 different patients 50 different times is going to give us the same result. So they agreed on that, but they still asked for approximately 24 patients So that's when the virtual cell question came into play. So this part is now things that we did not present to the agency. This is the future. So you could have chemicals, you could have drugs, you could stimulate cells with them, and then you could use that data to create a virtual cell. And that virtual cell can be different types of virtual cell, depends on what kind of information you think is useful to you, whether it's genomic data, it could be functional data, a bunch of different things. And what we did is we took a number of different inputs and a number of different outputs. So not single inputs such as milk allergen, but different cytokines, chemokines, different substances that we know stimulate basophils. And we selected a bunch of outputs that we know happen to the basophils, whether they appear on the basophil surface or secreted products. And we created, in the wet lab, an experimental system where we now have data that tells us in different concentrations of different things how basophils react across different types of patients that are allergic to milk. And then we feed this data into a computer program. And then we let AI analyze it in a way that now that we have the prior, I'll call this the wiring of the cell. And let's say we've now done about 50, 60 of these experiments. But once you have a good number, and the good number can differ between, depending on what you're testing. And in our case, it's going to be somewhere around 200 patients or so. Once you know the wiring, and then you could ask the question of an unknown allergen, whether it's present or not in the test sample you're trying to measure, with much fewer samples. And this will depend on how robust the wiring data is, but it will bring the, let's say, 24 patients that we need to do this to perhaps maybe 3, 4 samples or patients to be able to test. So this is some of our data from our training. Once we've trained the basophils on a computer model, then we could we could do an experiment where we have known different concentrations of milk, and we could stimulate the basophils with that, and we could feed that data into the AI model that we have and ask how much milk is in the unknown sample. Then we have a negative control and a positive control, and then we have, let's say, formulas that we don't know how much milk allergen is in it. Again, we do the experiment once, we feed the data into the AI model, and we let the AI model tell us how much allergen is in the test material that we have a question in. And the idea behind this to come up with some kind of a results that will give us a pass-fail. So this is again, a serendipitous thing that happened to us, which we were not trying to do, to utilize the basophil activation test, but here's a model that you could utilize to detect the allergen concentrations in an unknown sample. You could take it to the FDA, you could show it to them, and they would like it, and accept to use it in the phase 1 of a formula approval. And now with the use of AI, taking that approved concept to make the process a lot faster, quicker, with using less number of patient samples. And the future here would be in diagnostics, using these cells as biosensors. You could also apply this concept to drug response prediction. It does not need to be just the basophil. It could be T cells, B cells, other types of immune cells, or other types of tissue cells. You could use this in either diagnostics or predictions. You could use it in personalized medicine, and also to design smarter experiments. Questions are at the end, right? So, okay, thank you very much.
Thank you very much for this very interesting talk and movie. No, the questions in later, right? Okay. So it's my pleasure now to invite Svenja Keller, that's pronounced correctly. She is a biomedical research coming from us from the Institute of Physiology at the University of Zurich. And she will give a talk on an AI-based approach to identify lysosomal cysteine export regulating mTOR signaling. Please.
That's correct. Thank you very much to the organizer for having me here today. So as said, I'm not a computer scientist, I'm a molecular biologist. Nevertheless, I like to give you an overview how we use an AI-based approach to identify lysosomal cysteine export that regulates the mTORC1 signaling pathway. These are my disclosures. So by the end of my talk, you will be able to describe how genetically modified preclinical models of cystinosis recapitulate early onset phenotypes of this lysosomal storage disease and how they can serve as a translational platform to accelerate the drug discovery. You will be able to describe how artificial intelligence-driven target discovery platforms and cross-species validation pipelines accelerate the identification of important disease pathways and the development of novel therapeutics. And finally, you will be able to evaluate the biological role of nutrient sensing and lysosomal signaling pathways in maintaining the epithelial cells hemostasis. So cystinosis is a rare lysosomal storage disease that is caused by the loss of function mutation in the CTNS gene. This gene encodes for the lysosomal co-transporter cystinosine. In cystinosis, this leads to an accumulation of cysteine within the lysosome that disrupts its morphology and the function. Cystinosis is a progressive multisystemic disease. It affects different organs in the human body, such as the brain, the eye, the liver, the muscle, and the bones. However, the first organ to be affected by cystinosis is the kidney, particularly the epithelial cells lining the proximal tubule of the kidney. There, the lack of CTNS leads to dedifferentiation and impairs the reabsorptive function of the proximal tubule, which leads to the loss of low molecular weight proteins and essential nutrients in the urine, also known as renal Fanconi syndrome, which occurs early in life of children affected by cystinosis. The current standard treatment for cystinosis is with the drug cysteamine. Cysteamine helps to export cysteine from the lysosome. However, it comes with several drawbacks. It has to be dosaged very frequently, which is a problem in pediatric care. It can have severe side effects, such as gastrointestinal problems. Often it's poorly tolerated, and in the end, it has no effect on rescuing proximal tubule dysfunction. So therefore, there is an urgent need to develop better and safer therapies to treat cystinosis patients in the future. And this is exactly our goal by characterizing preclinical disease models that recapitulate very well the situation we observe in human patients in order to increase the chance of translatability when we discover novel therapeutic targets and pathways leading to disease progression. So one model we are using in our lab is the CTNS knockout mouse model. This model recapitulates very well important disease phenotypes of cystinosis, such as the accumulation of cysteine within the kidney. This leads to an enlargement of the lysosome, as you can see in the LAMP1 staining in the proximal tubule cells of the kidney of the knockout mouse model. This then leads to a disruption in the receptor-mediated endocytosis and finally to the loss of low molecular weight proteins, here shown by the CCC16 levels lost in the urine progressively over time. However, the mouse model is particularly interesting to us because it allows us to generate physiological relevant cellular systems to study disease mechanism. By microdissecting the proximal tubule segments of the kidney, we can culture primary cells of the proximal tubule, which we can then use to perform functional assay and apply screening technology. This cellular system is particularly interesting to us because it recapitulates very well the physiological characteristics of proximal tubal cells. They maintain a delicate balance between proliferation and differentiation. They express the endolysosomal system, and they have a high endocytic reabsorptive function. With this cellular system, we are also able to further profile the lysosomal biology, for example, by transduce the cell with the adenovirus, expressing the lysosomal transmembrane protein 192 that is fused to HA. We can immunoparticipate the lysosome using anti-HA conjugated dynabeads, which then allows us to perform proteomics-based profiling on the lysosome as well as targeted immunoblotting to better study disease pathways specifically on the lysosome. In CTNS-affected knockout cells, this means that the lysosome loses its endocytic degradation capacity, here shown by the magic red staining and the decreased maturation of cadepsin D, as well as we have an impairment of the autophagy pathway, here shown by increased expression of the lipilated autophagosome-associated LC3-2 levels. This was further validated by electron microscopy, showing an increased accumulation of autophagic cargo in the autophagosome and the lysosome in CTNS knockout primary cells of the proximal tubule. Another animal model we recently generated in our lab is the CTNS rat model. So compared to the mouse model, it recapitulates even better the phenotype we observe in human patients in terms of timing, severity, but also multisystemic involvement. Similar as in human patients, the rat model develops low molecular weight proteinuria very early in life, which leads to increased damage of the proximal tubule, and finally to the loss of the endocytic receptor megalin at the brush border of proximal tubule cells. It further then develops fibrosis in the kidney and finally kidney failure. The last model we are using to study cystinosis is a CTNS zebrafish model. In general, zebrafish can be used as a fast and easy screening tool to evaluate the potential of novel therapeutics. I will show you an example on that later. What is special about this model is a transgenic model for low molecular weight proteinuria. So it has a biosensor. We have the vitamin D binding protein. It's a low molecular weight protein that is coupled to the fluorescentic protein mCherry. So this protein construct is produced in the liver, is then secreted in the blood, and when it reaches the kidney, it's filtered by the glomerulus and then reabsorbed by the proximal tubule under physiological condition. However, in proximal tubule dysfunction, mCherry is lost in the urine, and we can measure it by ELISA. And this is exactly what we observe in the CTNS zebrafish model. We have an increased accumulation of cystine, as in the other models. Then in B, you see the impaired degradation by the lysosome, specifically in the pronephron of this fish, which then leads to progressive loss of low molecular weight proteins shown by mCherry levels in the urine. So with the help of these three animal models, our goal was to identify novel actionable targets in order to restore the hemostasis of the proximal tubule cells in cystinosis by rebalancing this balance between proliferation and differentiation in order to rescue proximal tubule dysfunction and prevent the loss of low molecular weight proteins in the urine. And to do so, we were using an artificial intelligence-driven target discovery platform. It's called PandaOmics. This work has been done in collaboration with In Silico Medicine. So what this tool is doing, it integrates multi-omic data coming from our animal models. For example, RNA-seq data coming from the micro-dissected tubules from the rodents, but also from the zebrafish model, and then proteomics and metabolomics data from the cellular system and from the immuno-isolated lysosome. It integrates this data then together with publicly available data. This can be from grants, from patents, from other publications, in order to identify potential targets that can be used in cystinosis. It selects it according to different criteria, such as the disease causality, the development status of drugs available to target this pathway, the druggability, the toxicity, as well as the novelty. So this analysis led us to this heat map with the top 10 targetable pathways associated with cystinosis. And you see on very top, we have the mTORC1 signaling pathway. So interestingly, when we performed KEK analysis in CTNS knockout cells, we found an enrichment in the mTORC1 signaling in red, but also pathway associated with mTORC1 activation, such as the metabolism of other amino acids, but also autophagy pathway. We further confirmed this by looking at the phosphorylation status of downstream substrate of mTORC1, such as S6 and 4EP1C, which are increasingly phosphorylated even under starved condition. Interestingly, in all our 3 animals models, we found mTORC1 to be hyperactivated in the total lysates of the fish, but also in the kidney of the rodents models, also showing this evolutionary conservation of the mTORC1 signaling pathway. So in the next step, we wanted to further explore how mTORC1 is tethered to the lysosomal membrane and activated. And therefore, we're looking at the protein complex formed by REC-GTPase, regulator, and VTPase that are translocating mTORC1 to the lysosomal surface in the presence of nutrients such as glucose, fatty acids, amino acids, also coming from inside the lysosome, where mTORC1 is then activated by the GTP binding protein Rep in order to promote anabolic pathways, while catabolic pathways are inhibited, such as degradation by autophagy and the lysosomal biogenesis. So indeed, when we immunoparticipated lysosome from CTNS wild type versus knockout cells, we saw that on the lysosomal membrane of the knockout cells, we have an increased expression of these subunits of the VTPase and the regulator complex. And this was confirmed in the IF picture. You see an increased colocalization of RAC-C with the lysosome. So to better study this cystine CTNS mTORC1 axis, we were wondering whether cystine accumulation per se triggers mTORC1 to be hyperactive. And therefore, we are using some pharmacological and genetic tools. So in the first experiment, we treated our wild-type cells with L-cystine and cystine dimethyl ester. In short, CDME, it causes the accumulation of the native amino acid within the cells. And indeed, we saw that CDME causes increased accumulation of cystine compared to L-cystine that is normally catabolized. And interestingly, on the right, you see that this was exactly what we had on the scaffolding complex. With the accumulation of cystine, we have an increased activation of the scaffolding complex at the lysosomal membrane. However, on the other side, when we reintroduced wild-type CTNS into the knockout cells, we could overcome the cystine accumulation compared to the disease mutant. And again, this was in line with a decreased expression of the scaffolding complex, tethering mTORC1 to the lysosomal surface. So, however, to actually validate mTORC1 as a therapeutic target to treat cystinosis, we were wondering what happens if we pharmacologically inhibit mTORC1, and we were looking at different readouts associated with cystinosis. So we were using our CTNS rat model, and we treated it for 2 weeks with low non-toxic doses of rapamycin. After this treatment, we collected the kidney, and we could confirm that we could not only overcome mTORC1 hyperactivation, but also stimulate the lysosomal catabolism, while we increased proximal tubule specific differentiation gene and downregulated the differentiation gene. And indeed, we saw an increased expression of the endocytic receptor megalin at the brush border of CTNS knockout-treated animals with rapamycin. So as I mentioned earlier, we are using our CTNS zebrafish model to screen for drugs and their effect on proximal tubule dysfunction. So also here, we treated the fish with rapamycin for 9 days, and we collected the tissue to perform imaging and the urine to measure mCherry. And indeed, we saw that with rapamycin, we could stimulate the lysosomal catabolism in the pronephron of the treated CTNS knockout larva. And this was in line with the decreased loss of mCherry in the urine, suggesting that we could improve tubular proteinuria. Overall, showing that the modulation of lysosomal mTORC1 signaling can be used as a targetable pathway in cystinosis. So with the help of our animal models, we showed that rapamycin can rescue lysosome differentiation and proximal tubulopathy downstream of cystine storage. However, we are fully aware that drugs such as rapamycin have some limited transability, especially in pediatric patients due to its side effects. Nevertheless, we believe that knowing that we can target mTORC1 as a therapeutic target, this opens up novel therapeutic avenues by using other drugs targeting mTORC1. One drug we are now studying are SGLT2 inhibitors. They're known to overcome mTORC1 hyperactivation, specifically in the proximal tubule of the kidney, and have recently been FDA approved to treat chronic kidney disease. So to conclude our findings, we could show that model system lacking CTNS recapitulate well the early onset of disease phenotypes that are associated with cystinosis, and they represent a powerful tool for drug discovery. By using artificial intelligence-driven target discovery platform and integration of multi-omics data, we can identify disease pathway paradigms in order to prioritize therapeutic targets and accelerate the drug discovery. We further explore the role of the CTNS cystine mTORC1 axis as a lysosomal signaling node in maintaining the hemostasis of epithelial cells lining the proximal tubule. And finally, by targeting this nutrient sensing and mTORC1 signaling pathway, for example, with rapamycin, we can prevent proximal tubule dysfunction in clinical models for cystinosis. Overall, showing that this can open new therapeutic avenues for therapies that target mTORC1 using other pharmacological compounds, but also nutritional strategies that have been described to have positive effect on mTOR hyperactivation in order to restore the cellular hemostasis of cystinosis-affected proximal tubule cells. So with this, I'd like to thank Dr. Alessandro Luciani and Professor Olivier Devust at the University of Zurich, and all our other national and international collaborators contributing to this study over the years. And with this, I'd like to thank you for your attention.
Hello. It is my great pleasure to introduce Dr. Shoshana Revel-Vilk, who is a professor of pediatrics, and she is the director of the Gaucher clinic at Shaare Zedek Medical Center, who is the largest Gaucher clinic in the world, to say. And her research actually is focused on the real-world data and using algorithms for the diagnosis of Gaucher disease.
So thank you very much, Özlem, for the kind invitation to this great meeting. I enjoy every year I'm coming. And I'm Taking you now for a more overview view on this topic, because I'm not a computer science also, I'm a public health specialist and a physician. And I would like to take this opportunity to talk about the use of AI in clinical trial development. I'll talk about the opportunities, and I'll give some examples from challenges and from lysosomal disease, including some things we have done in our unit. So these are my disclosures. And my learning objective today is to really recognize that clinical trials are more complex and expensive than ever, and to describe to you in a broad overview the use of AI in clinical trials, and then I will show some examples from lysosomal diseases and talking about challenges, especially in rare diseases. So when looking at clinical trial, you can see that there is over 4,000 studies running, which is a multiple by fivefold since 2005, with very increased invest. And you see here is a very low success rate of 12%. I'm sure most of you know these numbers. And it's a phase 3 trial studies now takes around 6 to 7 years to complete, with a very high investment of millions of dollars. And this is for several reasons. And when we look at the literature and try to figure out why clinical trial fails, so I think the main reason would be the poor recruitment and retention. And the literature say that about 40% of the trials have to be amended before even the first patient visit, and only 30% of the clinical trial hit the initial recruitment targets. And there is also the high participant burden with travel time, procedures, and limited engagement of the recruiters and trial teams. And there is also a big problem with design and methodological flaws, with inadequate endpoints, underpowered studies, and poor measures. Other reasons for clinical trial fail are efficacy and safety challenges. So about 50% of phase 3 studies fail due to insufficient efficacy, and also there is about 20% due to safety concerns. And the financial burdens we talked, and it's about 25% of the studies fail or stop due to lack of funding. And when you look at the rare disease scenario, you can see the same problems. So about 30% of insufficient patient accrual, safety efficacy problems in 25%, problem of funding in about 10%, and also problem of regulatory and conduct problems. So we probably can use AI for some of the issues, and I will show you some of the things that were already done and some that are already just for the future, but how AI was used for patient recruitment and screening, for clinical trial design and feasibility, and for data capture, monitoring, and analysis. So most of the studies on recruitment come from cancer patients, and this, you can see, is a systematic review of 10 papers of more than 50,000 patients with cancer, and they used AI tools, both reading EHR and NLP, so reading the text data and finding studies, and this is the pointer. So here you can see the positive predictive value. So the studies were quite good at finding patients, not excellent, but quite good, but they were excellent in excluding patients, so not including patients that would not be eligible by just looking at EHR and text data with significant time and cost reduction. This is a study from heart failure study, again, screening almost 5,000 patients. They had two approaches. One is AI EMR screening and compared to manual screening, and you can see here that those that were screened by AR, the numbers were much higher, and also the enrollment was much higher with AI compared to the manual screening, and it was also faster and much more achievable. There is two platforms that are used now for cancer patients, or at least are starting to be used. One is TrialMatch AI workflow with over 6,000 international cancer clinical trials, And this was validated, and it was found that 92% of the patients with solid tumor had at least one relevant trial retrieved within 20 recommendations, so very, very fast. And this is also a neat platform which is still under study, which is called Trial GPT. So basically, sorry, it's from the NIH, and basically this platform has 3 components: trial retrieval, trial matching, and trial ranking. And when they run it on a study basis, they found that more than 90, so for this case scenario, more than 90% relevant trials within a very short phase of time. So using those platforms to find and recruit patients more accurately. There is also tools, or trying to be tools to site selection, because we know site selection is also a big issue in large clinical trials. And here, it's not yet shown to be effective, but at least there is some thought of how you can take demographic data, disease prevalence, healthcare infrastructure, and other points of the different sites, and try to improve recruitment of sites that will be eligible for the study. There is also some platforms that try to do protocol optimization with different steps, steps that start with regulatory agents, regulatory agents, and then steps that are by the health technology assessment, and together to work to put a platform for the researchers and the protocol developer to really make more optimization protocol that would not be with missing endpoint and will not need to be amended several times. This is a very interesting study which I've seen, and taking the question how we can have less pharmacokinetic studies done. And here you can see they took 24 virtual patients. We talked about virtuals. They did a model of 49 time points, and you can see here that in 10 runs, they were able to reduce the number of points from 15 to 7, making the protocol much more efficient by reducing the time and the burden of the patient for the pharmacokinetic study. There is also now what we talked about, decentralized studies, so doing remote consent process, which would be more personalized, giving the patient more opportunity to ask questions and get answers. And there is this study that was done in more than 200 patients, showing the efficacy of doing a remote consent process compared to the manual one. We talked about decentralized studies, and I'd like to share with you this slide, because I know that during the COVID pandemic, decentralized studies was just going up. And you can see here, a little bit disappointing, at least to my point, that now it's go down again. You see here in this graph, the numbers are going down, and there is a lot of literature talking about how we can increase again the use of decentralized studies, especially in rare diseases. There is a AI that used data capture and monitoring. This is an example for Parkinson, but also for other studies with comparing traditional monitoring, which is a sensitivity of 70 to 75, compared to AI system, which have a 90% sensitivity and availability to have a more consistent and earlier detection of clinical changes. And there is also AI-based monitoring and quality assurance to make the studies more accurate, to have a real-time insight, not just to go to the centers every certain time, but go to be more active, proactive at screening the centers and identifying problem. It can increase efficacy and increase safety, because you can capture problems in real time and not just when you come to the sites. Clinic and standardization is a big issue with clinical studies, so AI tools to use and to help with that also. So let me just show you what was done in lysosomal storage disease, and a few examples. So I think for the point of view of AI-driven recruitment, there is some initiative in some of the diseases, this is from Fabry disease, to find patients. So this is a very interesting study doing AI and natural language processing to find patients with Fabry. It was done in Poland, and you can see here the confusion matrix and what they were able to show that the AI was very good at finding the patients. So 90% of the patients were found, and in the cohort that the AI thought they had a patient, so the 80 cases up here, they screened some of them, and one patient was found to be with Fabry. So showing that this way of doing AI diagnosis can help to find patients for recruitment, especially in rare diseases. We have done a study in Gaucher patients, again, not for purpose for clinical study, but developed a model to diagnose or to find patients with Gaucher disease. This model still needs to be validated. We didn't yet find new patients, but we were able to show that with AI, with machine learning, you can have a very nice AUC curve for finding patients with Gaucher disease, and hopefully in this way you can recruit patients to your study. There is also applying AI for echocardiography to find patients with Fabry disease. Again, another way to use AI for finding patients. There is one study on wearable in Gaucher disease in both type 1 and type 3. It was done on Apparato mobile app, and they collected several events, both sleep, walking, and several events, and they were able to show the efficacy of this way of studying the patients, both, as I said, in type 1 and type 3. We have just finished a study, and this is Professor Yaron Ilan, of trying to use AI to increase the efficacy of the treatment. And I'll show you what is the baseline for this and what we have done. So basically, the concept is called constraint disorder principle, saying that many things we are having have some variability, like heart rate, glucose level, immune system, and this variability is good. And when you don't have this variability, then you can have a problem, like if your variability is lost, you can have heart failure, or if it's uncontrolled, you can have diabetes, or you can have autoimmune diseases. So this concept he took further, and if you see here, so there is this what we call hemostasis, so it's like the regular rhythm that the variables go, but his philosophy, or his concept was that system should function with dynamics, with dynamic limits, and this variability might improve the response to treatment. And we took it a step further for our patients with Gaucher disease. So we know that about 10% of our patients with Gaucher disease, although they are treated, they have incomplete or diminished response. And what the thought was that we can apply this AI adaptive dosing, we can tailor the treatment and maybe improve the response. So it was a pilot study, 6 months, 5 patients with this mobile app. And you can see here a typical patient, so we had to define how often we want the treatment to be given, so between 10 and 18 days. And we also randomized the infusion time between 7 a.m. and 2 p.m., just trying to think that if we'll do the variability, maybe the patient would improve. Again, it was 5 patients, the pilot study, so we don't have a lot of data, but all patients completed the study, 100 adherence, and we can see that some of the patients did have some response or did improve both in quality of life, hemoglobin, platelet levels, and LDRTC. So again, it's a pilot and it's still to be proven, but it's a neat way to use AI for improving patient care. So just to summarize, I think we can all be convinced about the benefits of AI tools in clinical research, increasing efficiency and cost saving, improving accuracy and predictive power. The use of friendly interfaces also can promote patients' adhesion to the study, and the remote access and monitoring, I think, for rare diseases is a really important concept. We have drawbacks, and we have seen it in previous slides, of the data quality, the generability, the complexity, the black box we talk about, the lack of validation, and also the cost of implementing AI into clinical studies. And rare diseases, we have even more problem because we have less patients, and this also makes the challenges even more. And we talked, and we have seen about digital cell. So there's a concept of digital twins, which is actually similar concept. So instead of doing a cell digital, you do a patient digital. And this model of digital patients can also improve your study and maybe make similar studies with lower number but more information, and this can help. The digital twins in rare diseases can help predict future states, predict intermediate states, and predict population effects, again, using less actual patient and more virtual patients. So with that, I would like to conclude about the AI, which I think we all agree, and I think that's the theme of this meeting today, that can transform clinical trial across the full cycle, life cycle, and it could be unique value for lysosomal rare diseases, but challenges still remain. And with that, I would like to thank you for your attention. This is our group from Shaare Zedek Medical Center. If somebody is interested to join the working group in IWGGD, it's a working group for Gaucher disease. We are trying to work on digital health and AI for those projects, and thank you for your attention.
Very happy to have been invited to give this talk, and I'm sorry I'm not able to be with you. It was just impossible to squeeze Virginia in between Vienna and Stockholm in one day after the other. So I'm giving this pre-recorded talk. The title is Evaluating Osteonecrosis Using AI-Based Technology. The main author of this work is Boliang Yu, who was the postdoc who worked on this for 3 years. And this is part of the larger Gaucherite project in the UK. And here are my disclosures. And just a few words on osteonecrosis to put the talk in an appropriate setting. So osteonecrosis is the death of bone tissue, and about 43% of adult Gaucher patients in the UK give a history of osteonecrosis. And in that same study, it was found that osteonecrosis was the most important contributor to loss of quality of life. Now, the problem we have, and we'll come to this again later, is that estimations of prevalence of osteonecrosis is complicated by terminology and definition issues. And in this research, we focused on a radiological definition of osteonecrosis based on magnetic resonance imaging of the vertebral column and the femora. Now, it is important to measure osteonecrosis as to establish a baseline of bone disease severity, but also to attempt to optimize treatment. And as you will see in this talk, where I emphasize the questions of definition and terminology, that this work may contribute to the debate about standardization of our terms and our measurement tools. MR imaging of Gaucher bone, and I'll focus really here on marrow infiltration and osteonecrosis. The T1 weighted sequences are the most sensitive for bone marrow infiltration, because on T1 water is dark and fat is bright, and marrow infiltration is the replacement of normal fatty marrow with Gaucher cell infiltrates, which are higher in water. T2 weighted sequences are also used and can define areas of edema and inflammation. Osteonecrosis has characteristic features on MR, but the features do evolve over time. A number of the features include a region of low signal on T1 imaging with what's described as a geographic or sometimes called a serpiginous outline. Another feature on T2 is a double outline. And finally, where there are areas of low signal on both T1 and T2, that indicates a late process of sclerosis or calcification. So the objectives of this research were to segment or outline the marrow space within the spine and femoral images, to segment within that areas of osteonecrosis, and then by subtraction of osteonecrosis from the overall marrow space to give us the areas of marrow unaffected by osteonecrosis, which we are giving the initials UBM to. Once we've done that in the individual image slices, we can then render this volumetrically in 3D, and then from that we can quantify the volume of osteonecrosis that we're dealing with. And then finally, as a form of clinical validation of this measurement, we looked at correlation of the osteonecrosis thus measured with known clinical risk factors for osteonecrosis. The segmentation was carried out on the image database of the Gaucher study. In this study, 250 patients from 8 UK centres gave their consent to participate and share their images. We had, of the 250, we had 217 who had any form of MR imaging. Of those, 212 patients had spine images and 145 had femoral images. Each patient will have had multiple studies done, and so we will have had a total of 917 MR studies, each of which, of course, will have had multiple slices. And they were mostly, again, spine images and slightly fewer femoral images. Of that group, manual segmentation was done on 344 patients, but more split more evenly between spine and femur. So 176 spine, 168 femoral MR studies, again, each with multiple slices. And so from that number that were manually segmented, then the bulk went into the training of the machine learning, and then a smaller number went into validation and testing of the end result. So, as I said, manual segmentation was carried out on 344 MR studies, each with multiple, say, 10 or more slices, which was, therefore, as you can imagine, a huge amount of work. It was 18 months' work for an experienced image analyst. The segmentation was based on rules or clues, I suppose you'd call them, agreed between the clinicians and radiologists, which were in turn based on recognized MR features of osteonecrosis and known anatomic features. So the focus was on defining the border between marrow affected by osteonecrosis and unaffected. And this manual segmentation was, at least initially, an iterative process until we felt comfortable with our method. So for example, there were a number of decisions we made en route, which, for example, to limit the analysis to a subset of the width of the sacrum. We set minimal volumes for osteonecrosis, so something so small couldn't be osteonecrosis, had to have a minimal size to be labeled osteonecrosis. We would give a weighting, if you like, to favor areas that were confluent, to areas that appeared on adjacent slices, and areas that had a corresponding T2 abnormality to the T1 weighted image that we were mainly working on. And finally, one fly in the ointment that turned up a little later in the process was a confounding effect of what we might call heterogeneous marrow infiltration, and I'll show you some images of that later. This is the technical bit that I don't really fully understand. This is a cartoon of the UNET model used in the machine learning. It is, again, an iterative process going through sequences of, if you like, lower to higher resolution images, where the machine-generated image is compared with the ground truth or manually segmented image, and then iteratively gets better and better by comparison. So this is a slide showing you two different examples of the spine. So on the top three, you have the same slices through a certain individual, with the T1 on the left, the manual segmentation in the middle, and the automatic segmentation on the right. So you will see that the area in blue was the area of the marrow space drawn out manually, and the area in that rust color was the area of osteonecrosis drawn manually through interpretation of the T1 image to the left. And then after training of the system, the machine was able to generate from the T1 image an automatic segmentation of the marrow space and of the area of osteonecrosis. And I'll show you the degree to which these agreed. So again, on the lower half of the slide, you've got a different individual with osteonecrosis in the spine. So that was the spine, and similar then in the femur, again, two different individuals, T1 image on the left, manually segmented image in the middle, and the machine learning based segmentation on the right. Again, they look very close, and we'll see the extent to which they actually do agree. Now, in addition to those 2D representations, you can see also that we're able to render this in 3 dimensions, which I'll play the clip now. So in the color, you have the spine and sacrum, at least the central part of the sacrum. We were also able to train the system to recognize the individual vertebrae, so that we could, if we needed to, analyze, say, L5, L4 separately from the global amount of osteonecrosis. And you'll see in the 3D image in white, in a volumetric sense, is the amount of osteonecrosis in that individual. And I will stop it and let's move on to the next slide. There we go. So, and again, here is the equivalent of the femur, a 3D render of the femur, and the osteonecrotic elements in white within it. So I mentioned earlier a potential confounder, which was of heterogeneous marrow infiltration. This caused us some problems initially until we went back and repeated the manual segmentation to essentially label this as not osteonecrosis. And once we did that, then the machine learning system was able to cope and, again, not label it as osteonecrosis. So here's an individual who had this mottled appearance of the femur in 2012 before enzyme therapy, and it largely disappeared 7 years later on therapy. So it couldn't have been osteonecrosis because that doesn't disappear. So how well did they compare? How well did the manual segmentation compare with how well did the machine segmentation compare with the manual segmentation? And there are a number of tools in the AI imaging world. One, for example, is a dice coefficient, so the closer to 1, the better. And the system was certainly was satisfactory for both identifying the unaffected marrow and osteonecrosis, but it was better identifying the unaffected marrow, largely because that's a matter of identifying the anatomical landmarks, whereas measuring the osteonecrosis requires segmenting between diseased tissue and adjacent non-diseased tissue, and that is intrinsically more difficult. And the way I like, for my mind, the way I like to use it is over on the right. So this in millimeters is the distance that we can resolve, if you like. So for the unaffected marrow, we can resolve this down to a fraction of a millimeter, whereas for the areas of osteonecrosis, the resolution is, more than a millimeter, a millimeter and a half at the spine, and 3 millimeters in the femur. So segmenting the area of osteonecrosis is intrinsically more difficult than segmenting the marrow space itself. So having done that, we're then able to calculate volumes of osteonecrosis and measure it as a volume or as a fraction of the total marrow space. So one other thing we did was to categorize patients into having or not having osteonecrosis based on a very low fraction of osteonecrosis. So if it was 0.001 or if it was 0.001 or less, then they did not have osteonecrosis. Greater than that, they had osteonecrosis. So of the spine studies, MR studies, not patients, 520 studies, 97 had osteonecrosis. And of the 397 femoral studies, 99 had osteonecrosis. And the volumes of osteonecrosis and marrow space and the fraction of the space occupied by osteonecrosis are also given in the table. You'll see that presented graphically later. So here we are. So we looked to see whether our method of measuring osteonecrosis demonstrated the same risk factor profile as other historic research has done in the past. So was there a relationship with splenectomy, for example? Was there an effect of the untreated disease duration? And this here is the data we had on splenectomy. So we had 212 patients in this analysis. 59 had been splenectomized, 153 were not splenectomized. And you see on the top left the volume of osteonecrosis was significantly greater in the splenectomized group than the non-splenectomized group. And it was virtually the same when you look on osteonecrosis as a fraction. If you wish to do it as a categoric variable, so looking at the distribution of osteonecrosis, yes or no, according to splenectomy status, again, by a chi-square test, this again was highly significant at the spine. It was also significant for the femur, but much less so. So there was a very strong effect of splenectomy on osteonecrosis in the spine, but a less dramatic effect on osteonecrosis in the femur. Significant, but less strong. A further known risk factor is the interval between diagnosis and treatment, or the interval, in this case here, between the first symptom of osteonecrosis, or first symptom of Gaucher disease, and the start of specific treatment. So you'll see that that interval is greater in those that have osteonecrosis in blue here, this violin plot, an interval of a median of about 30 years, whereas the same interval was 10 years or so in those that did not have osteonecrosis. You will see that there's a group there among the patients without osteonecrosis where the interval is less than 0. In other words, they started treatment before they developed any symptoms. There's a small number subjects. But in that group of subjects, there was no osteonecrosis. And so that was, on the left is spine, and on the right is femur, and again, the same relationship holds up. We also, in a sort of exploratory way, wanted to see whether the BMB score had some bearing on the volume of osteonecrosis, and it was, if anything, a very weak relationship, and only at the femur. There was no relationship at the spine. So there seems to be a different pattern of risk factors working at the spine and the femur. So a number of, I suppose, caveats to this research. One being that we started to look at how would this work for longitudinal analysis. And we found that with changing MR technology, changing scanners, changing scanning profiles, that it didn't work quite so well, and we need to do a bit more work on this, put the system through further training with more divergent forms of scanning. This quantitation is very much dependent on the original input, so our original definition of osteonecrosis and the original rules that we as a group of people put together to guide the manual segmentation. So if you can't really accept the quantitation without accepting the underlying inputs that went into it. And you'll have seen in the comparisons that segmentation of anatomical boundaries, in this case the main factor in the unaffected marrow, is more precise than boundaries between diseased and non-diseased tissues, which are intrinsically a bit more, what's the right word, imprecise. So in summary, we demonstrate a new method to quantify osteonecrosis using machine learning. The method shows good agreement with manual segmentation. We have replicated established risk factors as a form of initial clinical validation, and have seen some early signs that perhaps the risk factor pattern for osteonecrosis at the spine and hip are subtly different, where splenectomy is a much stronger risk factor at the spine, and marrow infiltration is a stronger risk factor at the hip. And finally, to acknowledge that this study was a subset of a larger study awarded by Sanofi, and the Gaucherite study itself was funded by the UK Medical Research Council. Thank you very much.
Now it's my pleasure to present Ravi Kamath. He will be talking about assessment of bone involvement in Gaucher disease using advanced imaging and AI. Ravi is an assistant professor of radiology at the University of Virginia School of Medicine.
Okay, so what I'd like to do today is to build on what Dr. Deegan just told us and speak more broadly about the use of AI in the diagnosis of findings that we see with Gaucher disease. These are my disclosures, and these are some of the learning objectives. And this is a basic outline for the talk. So I'm going to start by showing you what are the basic imaging features of Gaucher disease, specifically focusing on MRI and a comparison between X-ray and MRI. Then I'm going to talk about some of the applications of AI and machine learning and radiology in general, and define specifically the term of radiomics, which is a more advanced form of AI, a predictive form. And then I'm going to talk about the applications of AI and advanced imaging in 4 of the major complications of Gaucher disease in bone, including fracture, osteonecrosis, bone lesions, and dark marrow. So, as most of you probably know, Gaucher disease is a result of a deficiency in the enzyme beta-glucosteroperoxidase, which results in an accumulation of glucosylceramide, which accumulates in these Gaucher cells of the monocyte macrophage system. And this results in the skeletal complications that we see in the vast majority of patients. Imaging of Gaucher disease is typically done using radiographs, MRI, and DEXA. Radiographs can show a wide range of bone pathology, but they're relatively insensitive. MRI can show the same findings at a much earlier stage, and also has a unique feature of being able to characterize the bone marrow as so-called dark marrow. DEXA is specifically used to assess bone mineral density. On MRI, bone marrow that's infiltrated with Gaucher cells typically appears hypointense or dark on both the T1 and T2 weighted images, which is why it's called dark marrow. And MRI is very sensitive for detecting all of the major bone complications that we see: fracture, osteonecrosis, as Dr. Deegan just described, and focal lytic bone lesions. So here are examples of MRI images on 2 different patients with Gaucher disease. So here on the left, you can see a patient with relatively mild disease where there's only a little bit of bone marrow infiltration in the upper parts of the femurs. And here on the right side, you can see a patient with much more severe involvement, asymmetrically involving one of the femurs, including osteonecrosis of the femoral head with collapse and focal deposits of Gaucher cells throughout the bone. Here, looking at the lumbar spine in 3 different patients, we can see first a patient with milder Gaucher disease with diffuse dark marrow infiltration, a patient with more severe disease with more dark marrow and the early signs of deformity of the vertebrae. And then here on the right, we can see a patient with very advanced Gaucher disease, including diffuse bone lesions, osteonecrosis, and also deformities of the vertebrae. So one of the things that we can see on MRI is that patients who are treated actually can show an improvement in their background bone marrow. So here's a patient who underwent therapy, and you can see from baseline to 1 year, 2 years, and 3 years, there's a progressive decrease in the amount of dark marrow that we can see. And we see this in about 2/3 of patients on both enzyme replacement and substrate reduction therapy. So now I'd like to show you just comparing X-ray versus MRI. So here's a patient with dark marrow infiltration throughout the femur with relative sparing at the ends of the bone, which is a characteristic distribution. And this is an X-ray image from the same patient. And you can see that although there's a sharp interface between the dark marrow and the regular bone marrow on the MRI, there's really no difference at all in the density on the X-ray. So that's why dark marrow can really not be seen on X-ray. Here's an example of a patient with compression fractures in the spine. And on the X-ray, we can very clearly see that these 2 fractures are there, but we cannot tell whether they're acute or chronic. Whereas when we do an MRI, we can see that there is edema inside the vertebrae, suggesting that these are acute or subacute fractures, which could be responsible for the patient's pain. Here's an example of a patient with osteonecrosis. As Dr. Deegan described, on MRI, you can see this area of geographic hypointense signal, which outlines the area of osteonecrosis. But the X-ray in this patient is completely normal. And by definition, that's grade 1 or stage 1 osteonecrosis because it's invisible on the X-ray. Here's another patient with osteonecrosis, sometimes also called marrow infarction when it occurs like this away from the joint. And this patient has, you can see here in the proximal tibia, an area of indolent or chronic marrow infarction without any adjacent inflammation, whereas in the distal femur, you can see that there's an area of osteonecrosis with adjacent marrow and soft tissue edema. So that, again, shows us that this is acute and could be responsible for the patient's pain. Here's an example of a lytic bone lesion in a patient with Gaucher in the tibia. And what's interesting, in this patient, you can compare the MRI. The only part of this bone lesion that you can see on the X-ray here as this dark spot is the area where the lesion has broken through the cortex. And the full extent of this lesion is not visible on X-ray and is only visible on MRI. So now I'd like to just step back a little bit and talk a little bit about the use of AI and machine learning in imaging. So we've already seen lots of talks about AI, and so hopefully we're all kind of familiar with these terms. But just to speak very broadly, right, artificial intelligence is the overarching category, machine learning and deep learning are subsets of AI, and convolutional neural networks are the tools that we use in order to implement AI. So the development of AI models requires training on large data sets with high quality images and annotations, and the quality of the underlying data set determines the quality of the deep learning model and the output. Now, radiomics is a specific term which basically describes the use of advanced mathematical analysis to perform high throughput extraction of quantitative features from imaging. In other words, it can be used to discern features that are not visible to the human eye. So the idea here is to allow the AI to give us information that a human observer cannot discern. So what are some examples of this? For example, if you have a tumor, it could identify tumor characteristics that correlate with how the tumor will respond to treatment and the patient's likelihood of survival. It could create a computational model to help with personalized diagnosis and treatment. It could detect subtle signs of drug efficacy and safety, and it could identify patients who are more likely to respond to a particular treatment. So just to pick an example of something that's really easy to see, so here's an example of two different patients with soft tissue tumors. And you can see the first patient has a lesion which is very well circumscribed. It's bright on the T2 with septations. So to my eye as a radiologist, this looks like a lesion that I would favor to be relatively benign or indolent. In comparison, the patient here on the right has a lesion that is heterogeneously T2 hyperintense, so it's solid, and it has more ill-defined margins and it looks invasive. So again, to my eye as a radiologist, this looks like a more aggressive tumor. So the AI tool approaches this by segmenting the tumor, as Dr. Deegan described. First, you have to be, the tool has to be able to determine what is tumor and what is not tumor. And then the tool will extract the radiomic features. Now, as a human, we look at things like the shape, the size, and the signal. The neural network uses a different set of criteria. It looks at the shape, obviously. It looks at something called a histogram, which is basically a plot, a distribution plot of the signal in the lesion. And the shape of this histogram is very, very important. And then finally, it looks at what is called the texture of the lesion. It feeds this into the machine learning model, which also has additional biologic, histologic, clinical data fed into this model, and then based on that, it can make a prediction. And in this case, for example, the model would predict that this has a relatively low risk of metastatic disease, and this one has a higher risk. So the idea of using AI or machine learning in Gaucher disease specifically, so the first thing we'd like it to do is to be able to identify areas of fracture or osteonecrosis on both X-ray and MR. And even beyond that, right now, we're really required to use MR as a tool to determine acuity, but could, for example, artificial intelligence determine acuity on an X-ray instead of an MRI, which would be a much simpler test. Again, in order to do this, we need to be able to segment the bone from the soft tissue, so we have to know what is bone and what is not bone. I think that's something that's easy for a human, but maybe a little more difficult for an algorithm. And then within bone, to segment and quantify bone lesions and osteonecrosis from the background bone marrow. So this is an example of what Dr. Deegan showed, and I'm going to kind of build on that a little bit. And then finally, let's say that we have a patient who has osteonecrosis. Can the radiomics predict the risk that that patient is going to suffer from articular surface collapse? And then finally, once you've segmented the bone and you know what is bone and what is a bone lesion, then you can analyze what's left, which is the background dark marrow. Okay, so let's talk about each of these in turn. And I should start by specifying that a lot of these studies, they're not from Gaucher patients, but the idea is that it's analyzing the same types of clinical features that we see in Gaucher. So this is fracture detection. I should start off by stating that there are a lot of already widely available commercial algorithms that are out there that are being deployed in routine clinical use. So I'm going to kind of focus down a little bit more and look at the identification of fracture acuity. Okay, so here's an example of a compression fracture that you can see here, and there's no edema associated with that. So although you can see a fracture, it's chronic and it's not really clinically significant in this particular case. Here's another case where you can't really see a fracture, but when you do the MRI, you can see there's edema. So there actually is a fracture, but you can't really see it on the X-ray. So these are two confounding clinical scenarios. So the way that this algorithm works, just like a lot of these, right? So you first have to identify the fracture. So once you're able to segment the fracture, you can crop and isolate it to that one vertebra. You feed it into the neural network, and then you determine an output in terms of the probability of fracture acuity. So what's interesting when you look at this, right? So here's examples of true positives, false positives, true negatives, false negatives. Let's sort of focus on this quadrant here for a minute. So as a radiologist, I look at this vertebra and I can see clearly that there's an end plate deformity, and I can see a little fleck of bone here. So this is an area that is of particular interest to me. And indeed, the algorithm, this is a heat map showing the areas that it thinks are most strongly correlated with its prediction. It identifies this as well as an area that is particularly concerning. Now here's another patient where it identified actually an area in the pedicle that it finds is very highly correlated with the fact that this is an acute fracture, which is something that I don't see anything there. So it's able to see something beyond what a human is able to see. As you can see overall, the machine learning model has a performance that is similar to or exceeding that of an experienced spine surgeon. And another paper has shown that when you combine the algorithm with an experienced image expert, like a radiologist, then you can get even better performance. But as with all the things that we do with AI, you know, the quality of the input determines the quality of the output. So really, you need to have good images with low artifact in order to make this work. And as with many of the deep learning tools that we're using, it provides these results, but without it being clear what are the specific prognostic features that it's using to make that determination. Okay, let's talk about osteonecrosis. So we already talked about osteonecrosis has different stages of severity, ranging from stage 1, where it's only apparent on MRI, to stage 4, which is where it's very severe with articular surface collapse. And in general, machine learning algorithms are very good at the detection of osteonecrosis. You can see that there's a sensitivity and specificity that are very high. When we also compare this to an experienced radiologist, so if we compare it to an inexperienced radiologist, the machine learning algorithm is superior, and the machine learning algorithm is similar or maybe slightly worse than an experienced radiologist. So this is the work that Dr. Deegan just described, so I won't reiterate it here. But the point here is that the deep learning algorithm is able to accurately segment areas of osteoporosis from the background bone marrow in the spine and the femur. So now let's talk about prediction of femoral head collapse. So again, this requires first to segment the bone that's affected, and then feed it through into the model, extract the radiomics features, and then perform a prediction. So here are some examples of segmentation, right? So here on the top is just the unadulterated MR images, and here is the machine learning tool segmentation and the manual segmentation. You can see that they match pretty clearly. Here on the right is an example of 3 different patients. So this is a patient who did not have femoral head collapse that was correctly predicted by the algorithm. Here's a patient who did have femoral head collapse that was correctly predicted by the algorithm. And again, just to the naked eye, you can see obviously in osteonecrosis, size does matter because larger lesions are more prone to collapse. And here on the bottom is a patient that was incorrectly predicted by the algorithm. You know, so again, it's not perfect, but it does have some ability to differentiate. So here's the ROC curve of the performance. I should also state at baseline, prediction of femoral head collapse is something that's very difficult to do even clinically. And as you can see here, the algorithm has a performance which is pretty good, but it's clearly better than that of the human. So again, just kind of taking a look under the hood and understanding what the neural network is looking at, you can see that the criteria that it's using are things that are really meaningless to humans, right? It's looking at grayness, kurtosis, which is about how tight the curve is, skew. Like these are the criteria that the deep learning algorithm is using to make these predictions. Okay, so let's talk about detection of bone lesions. So again, there are a number of tools that are widely available to assess for bone lesions, and overall, these do a pretty good job, as you can see here. And the ROC curve you can see is excellent. This is, again, a confusion matrix showing that it's able to detect accurately most of the bone lesions. And what I'd like to do now is to show you an example of a kind of trickier case. So this is an example of patients with multiple myeloma. So these patients, by definition, have a background abnormal bone marrow, and so we're trying to detect bone lesions within abnormal bone marrow, which is kind of more akin to what we do when we're treating patients with Gaucher. So again, in order to do this, we have to be able to segment the bone lesions from the background bone marrow, and then we have to be able to highlight those lesions. So here's an example of 2 cases where the AI was able to accurately define the bone lesions. And here on the right are 2 cases where the AI missed bone lesions. Okay, so again, it's not perfect. And so overall, this is a much more challenging clinical scenario than the ones that we saw earlier. So here, the success rate of the AI is much lower, more in the sort of 50 to 60% range, as compared to the earlier tests that we saw. Okay, so now let's talk about dark marrow and fat fraction. So, this is a study which used a deep learning tool for the high throughput bone marrow fat fraction analysis using a large data set from the UK Biobank. And they developed a new lightweight attention-based UNet model for segmentation. And then they determined the fat fraction within the bone marrow. So as Dr. Deegan described, this is kind of complicated because MRI images are in 3D. So first you have to decouple those images, feed them through your network to determine what are the areas that you're going to analyze, and then recapitulate the original segmented images and then do the analysis. So this is an example of the algorithm trying to do this in different areas. So there's the computer-based model, which is or the human model, which is in purple, a computer-based model, which is in yellow. And you can see that in the spine, in the femur, it actually does a pretty good job in the hip area. But in the femoral diaphysis, it was much less consistent overall. And using these same kind of violin plots, you can use this to see whether things that we know correlate with abnormal fat fraction, for example, osteoporosis. We can see here that there is a correlation, just as we see we've seen in other studies. So the idea is, this is something which is kind of looking ahead to the future, but the goal would be to combine multiple different deep learning algorithms in this way in order to be able to segment the areas of osteonecrosis and bone lesions from the remaining bone, and then to determine the fat fraction of the background bone marrow. And all this could be done in an automated fashion, right? So the idea here is to essentially be able to have the deep learning algorithm analyze the MRI and potentially give a quantitative measurement about fat fraction from background bone marrow. So this is potentially useful in clinical application because it isolates this background bone marrow, which is the most susceptible to treatment effect from these potentially irreversible bone lesions like areas of osteonecrosis. We can quantify the amount of dark marrow in specific portions of the bone. So for example, looking specifically in the hip or looking at the femur as a whole. It allows for a more standardized assessment of MR, which right now is difficult because different people are doing it different ways, and potentially the ability to quantify the amount of dark marrow, which is something that I think it would be potentially very useful. And then also we could quantify the size of osteonecrosis and bone lesions to determine areas of focal structural weakness of bone and that are at risk for insufficiency or pathologic fracture. So in summary, bone disease is present in most patients with Gaucher, with dark marrow, fractures, osteonecrosis, and bone lesions that can be seen on imaging, usually X-ray and MRI. AI and machine learning are useful tools for assessing X-ray and MRI images in Gaucher disease. So first, we have to be able to segment or outline those lesions, and then we have to be able to analyze those lesions. And this can aid us in interpretation, to quantify severity of disease, and to assess for more minute changes in disease severity or response to therapy. And we have this concept of radiomics that offers the potential to characterize disease findings by looking beyond the images, by being able to analyze the images in a way that humans are not currently able to do, and to provide information that can only be done by a machine learning algorithm. That's it.
We have 20 minutes for questions, and Patrick is, I think, online. So this is an excellent topic, actually. AI is becoming a very important part of our lives, and hopefully it will be used in a good way. But we learned that there are many opportunities to use it in clinical trials or even assessing the clinical imaging to get better reading.
So maybe I'll start. So I was very intrigued by the virtual basophils, and we know there is a problem of drug hypersensitivities. Do you think this model can be used also for those type of studies?
Yes, so it can be, as long as the mechanism is IgE mediated, because the basophil response is strictly an IgE mediated process, but the answer is yes. What I showed you, though, is not using basophils in diagnosis of disease, but it was more using them as biosensors of, let's say you have something that you want to measure the milk amount, the peanut amount. It could be used in the food industry, for example, to detect how much peanut is in a peanut bar, etc. So it was a different use rather than using it in a diagnosis of a disease setting. But using AI to make that a much better tool is absolutely critical.
Could it be used for therapeutic, for finding therapies, this model, or has it been used?
I don't know, good question. I haven't thought about that.
You think it can also give us some suggestions about what medications to use, type thing?
Sure. So in the presentations that I did, in the first one in the morning, you can use AI to ask questions about potential treatment modalities that may not even, like, as humans, we may not even recognize. So the answer to that is yes. However, I think the value of this will become asking a question to AI first, and then taking that information, taking it back to the clinic or the lab, and adding more data, and then coming back to AI and saying, okay, so I've added, these experiments from the lab, these experiments from the imaging studies that I've done. So why don't you reanalyze the question? Would your suggestions change or not change? I think that's what needs to be done in asking questions about treatments. So definitely, but I don't think the answer will come just us putting inputs and looking at outputs. There's a little bit more layers to it.
Hi.
Yeah.
Okay. Judy Hill from Santa Fe. So thank you all for a series of really interesting talks. And my question is really for Dr. Deegan and Dr. Kamath. To what degree is AI imaging already being used for Gaucher patients? And what do you do clinically when AI calls something and you don't see it yourself? Do you have a protocol for how to handle something like that? He probably went to bed, so maybe you can.
Let's see, is this, okay, there we go. So right now there is no clinical package for the use of AI in Gaucher disease that is widely available or commercially available. The tool that Dr. Deegan described is something that they developed. As far as I know, it's not being used in routine clinical practice, but I guess you would have to ask him that. We don't have the experience of doing that in Gaucher, but I can say that we've been using AI in radiology actually for probably close to 20 years. So for example, some of the earliest examples were in mammography, where before, for breast cancer screening, we would have two separate radiologists. And then in the early 2000s, some algorithms were developed that were used essentially to replace the second reader. So the AI tool would identify an abnormality, and then the radiologist would come back and look at that and determine whether that was something that was real or not. And because ultimately the responsibility for the output of that falls to the radiologist. So that's the way that it's being used. Now, there's a question of whether AI will ultimately completely replace a radiologist, right? So in that case, that's a decision that would not be made by a human, and that's where it becomes more complicated in terms of both the clinical implications of that and also potentially liability issues as well.
What about AI tools for DEXA? Because I think we are most using DEXA in our patients than MRI. At least we are not so much using MRI. Are there AI tools for DEXA studies?
Yeah, so there are. So the AI tools that are being used for DEXA right now are for segmentation, basically, right, for outlining the vertebrae. But those are still things that they're done automatically, and again, they have been done automatically by machines for a long time. But they're validated by the technologist who operates the machine to make sure that the outlines look correct. And then when the exam is ultimately read by a radiologist, the radiologist again reconfirms the segmentation is done correctly, because ultimately that's what determines how accurate the data are. That said, for bone mineral density analysis, there are a lot of new emerging tools that I didn't even get a chance to touch on today. But there's a lot of papers have been published recently about the idea of opportunistic screening, that when you have a test done for another reason, you can actually determine the bone mineral density from a test that's already been done.
including CT surely, but also MRI. Within the last 4 or 5 years, we've been able to start using in clinical practice. For me, every day now I use it, a way to basically replicate CT images, but on MRI. So you can actually look at bone structure and trabecular structure on MRI, which is something that's relatively new.
Shinji Thomas, Numerous Children Health. Thank you very much. This is a very interesting talks. So first, radiological point of view, what kind of a parameter you should correct first? Still, I don't understand. Let's say bone mineral density is fine, but when you start, which parameter or which measurement you should correct? How you determine before you put the data through AI? That's the most critical point for us. What kind of a biomarker? Which biomarker you want to correct at the beginning? Who determines that portion?
I'm not sure I understand your question. So you're saying which imaging feature you want to focus on?
Yes, or whatever, yes.
So
that's quite important.
Yeah, I mean, the answer is you can develop a tool that focuses on any imaging feature, right? So in this particular case, Dr. Deegan decided to focus on osteonecrosis because in his patient population, that is something that it contributes significantly to morbidity. And so he developed a tool that focused on that. But as I showed you, that you can generate a data set, a baseline data set for any of the imaging features, and then you can use that to build a tool to analyze each of those in turn. That's why, when these deep learning algorithms are available, they generally become available as modules. Like it's not like you get AI and now AI can do everything. It's like you get an AI tool to look at the bone lesions. You get a separate AI tool to look at osteonecrosis. You get a separate AI tool to analyze fat fraction, and you have to put all those together in order to get the final output that you want, which is to look at everything holistically.
So as broad as better or as narrow as better at the beginning?
I think you're better off starting as narrow as possible so that you can very clearly define what it is that you're looking for. Because again, the thing that most clearly determines how successful and how useful the algorithm is the input, the data set that's used to generate the algorithm.
All right. One more question about food allergy.
Can I add something to the question you asked?
Yes.
So what we've done with the Basel experiments we've done is we've gone back and asked the question, what did we forget? So we let AI tell us what the inputs that should also be included in the testing. So the question you're asking, you could ask the AI. You could
Okay.
start with something.
All right.
That knows, but yeah, because the AI can figure that out better than you.
Oh, okay. Sounds good. Yeah, that's fantastic. Okay. About food allergy, most of a baby will not get milk allergy or whatever. So can you predict, let's say, food allergy or ultimately more strong immune reaction babies or not? Or in future, maybe whatever treatment is that? Is that possible or not? Prediction, I'm talking about.
So is the question predicting severity of the allergic reaction?
Yes, or food allergy, whatever, yes.
Yeah,
Not
so-
afterwards, not after onset, before.
Yeah, so probably, but we're not even close there yet.
Okay, thank you very much.
All right, first question is to Ravi. Maybe I can expand Dr. Thomas's question. So basically, whatever AI does, I don't agree with everything, like within the expertise. Actually, I occasionally go check myself, and sometimes it is not really correct. So like the correlation, I mean, whatever you data put in, Dr. Deegan presented, there was a correlation with splenectomy and then the vertebral osteonecrosis. I followed actually hundreds of patients with Gaucher disease, meaning over the years, and then this is not my experience. I mean, the osteonecrosis actually there's a limited number of splenectomized patients, and actually my experience is like more femoral or hip necrosis, and then occasionally they're coupled with, with the vertebral osteonecrosis, and then, the other bones like the shoulder, et cetera, et cetera. So this can be an ascertainment bias, is that right? I mean, we cannot predict currently with the current models which patient is going to get what kind of osteonecrosis. I mean, there can be predictive models with inflammation, high lyso, this and that. So how can we design the data feed or the whatever you're asking the question, the prompt? So basically you kind of minimize the ascertainment bias, so we really, have that kind of conclusions at the end, which may or may not be corrected, at some point.
Yeah, I mean, I think, the thing that is most important is to, again, it's all about that original data set, right? And so, the question is the original data set that was used to generate the algorithm applicable to your patient population? And if the original data that were used are somehow different, then it's not going to be applicable to your population. And so this is one of the difficulties of using these tools, is that we're generating these tools using a data set that comes from somewhere, and then we're applying it more or less universally, and that's one of the major weaknesses of the deep learning algorithm. You can't generate a unique deep learning model for every geography and nationality and genotype, and that's not really practical. So at some point you have to allow that the technique is going to be imperfect, but hopefully it will do things in such a way that you can then, it'll be easier to curate, for a human to curate an existing analysis rather than to replicate the analysis. So for example, in Dr. Deegan's talk, he showed how in order to manually segment all those MRIs, it took one person 8 months or whatever to do. And so it would be a lot easier if that person, instead of having to outline every area of osteonecrosis, could just say, yeah, that looks pretty good. And so that's the idea. It's to speed up what we do, not necessarily to replace us. I think that's what we're coming to learn more and more.
All right, thank you. And a question, really quick question for Dr. Keller here. So about the mTOR pathway. So do you think it is so basically it is rapamycin as a condition we use for immune suppression, is that right? T cells go apoptosis and kidney disorders become inflammatory at some point. Okay, so how do you differentiate between this is just the T cell suppression, thus the prevention of inflammation, versus mTOR only, like the lysosomal enhancement?
Yeah, it's a good point because it's not selective.
Yeah, exactly.
The rapamycin is not selective only on mTOR1. It has an effect on mTOR-C2, the immune system. So it was more for us a proof of concept that if we inhibit mTOR-C1, we have an improvement in proximal tubal dysfunction. But I fully agree with you, it's not something we would use in clinics in the future. And also there is a delicate balance in mTOR-C1 activation, so we cannot completely block it. It's important also mTOR-C2 that is affected with rapamycin. It's important for the integrity of kidney cells, such as the proximal tubal and the podocytes. So for us, it was more, as I said, a proof of concept and to find other therapeutics that can block mTOR-C1 without this side effect that rapamycin brings. I hope this answers the question.
I just want to say that as a pediatrician, we use a lot of rapamycin in children, and there is side effects, but it's quite safe. Like we use it for different hematological diseases, vascular anomalies, so we do have experience.
Okay.
Yeah.
Okay.
Or one more quick question. So preventing, immune response to gene therapy or ERT is very keen. Again, before onset, we know general cream negative patients should have more immune reaction. That's fine, okay. But beyond that, is there any, predictable marker or biomarker for the immune response. These patients may be high risk to respond to ERT or gene therapy. Is there any such algorithm or predictable model can be done or not? That's maybe quite important. That not only one disease, but LSD entire world. It should be quite important to predict before treatment. These patients are high risk or not.
So this is before even giving the patient the drug.
Right.
To predict if that person is going to be the high immune response person.
Right.
I think it can be done, but I don't think such an algorithm exists clinically.
That should be done. Then universally, everybody should be very happy. We have it.
Actually, I can do a comment on that. I think we need to immune phenotype all these patients going through the gene therapy and get the responses. The reason we had a case that had an untoward response, and we thought it was the complication of gene therapy, but then we went back and looked at we had collected samples over 10 years, and we did immune phenotyping, and the patient had the abnormal clone cells for a long time. So basically, it is very important to understand which patients these are and what kind of response that we can expect. I think with the current knowledge, we're just going to blind into a kind of an area we're going to discuss more, which is very little known about it.
But saying that, I think with the advance of the AI and the machine learning, the advantage is that you put in things you don't know that they are expecting. So when we developed our algorithm for diagnosis of Gaucher disease, we realized that we found many features that we weren't even aware that they are correlated to Gaucher disease. So I think the advantage of doing supervised or unsupervised machine learning is to really learn things you didn't think about. The things we know about, we do them and we test them. The issue is to find or think about or find things that we're not expecting, the black box, and trying to analyze the features that are important and trying to figure out how they can help us predict or treat or predict who will respond to therapy, who will be diagnosed with something.
But I'll add something a little bit practical to your question. So if you're asking from a research aspect, that's fine. You could, plan these studies, do them prospectively. It'll take very, very long time, but can be done. But somebody has to fund it, NIH, etc. But if you're trying to collect this info from clinical practice, unfortunately, most physicians, the way they practice is a very Band-Aid approach. So the patient comes with a problem, you put a Band-Aid on it, and you send them home. So you don't get any sort of deep information. With that type of a practice that's very broadly practiced, it's very difficult to get the information you're asking from. If you're going retrospectively back and asking the questions on, okay, so let's look at 50 Gaucher patients, but all the data that you have from them are basic things. They're not going to give you that answer. Nobody's looked, because the way most physicians practice is a very sort of let's put the boo-boo Band-Aid on type approach. It has to be done, either the way people practice has to be changed, or you have to do it prospectively as a part of a research protocol.
I think changing the practice, asking to AI, and then whatever AI is saying and doing it on a patient will be extremely dangerous thing to do too, right? At this point, I think we are just learning. I think you said it was very good point. So at this point, AI is helping us to improve or augment our decision, not to guide us with the decision, right? So I think from the imaging reading standpoint, it may help because you show something inexperienced readers versus experienced readers. It helps the inexperienced readers, right? And then we get imaging, and then it says white matter changes, and interpretation is that findings are consistent with mucopolysaccharidosis, which is absolutely not true, but it is read by inexperienced radiologists. So AI may help those individuals to make more meaningful differential diagnosis, right? Because experienced radiologists can easily differentiate metachromatic leukodystrophy from XALD or L2-hydroxyglutaric aciduria from something else. AI may help in this type of situations.
Yeah, I think AI will help. If you're the expert or if you have the expertise, I think AI will add to your current existing knowledge, because obviously you can't know everything, but you can easily differentiate which is correct and which is like, garbage that is included in AI. But on the other hand, AI actually can help with straightforward things like designing experiments. Actually, Dr. Alpan said that you can ask AI. It can design wonderful experiments, actually, because this is all set methodology. But, we are not dealing with methodology here. We're dealing with human biology, which it can be very different from person to person.
Any other questions or comments on AI? How many of you are using AI?
But just going back to what you said, I think the field, at least when I reviewed now the literature, I think the field, because they're afraid of AI and what AI can just make knowledge without any basis, most of the way now they look at the AI that they want to put, so I showed this platform of developing or optimizing protocols. So there were 3 steps they are going to do. And the first step is by the regulatories. So the regulators will do the first step of building all the background, taking a lot of data together, and this would go to the local healthcare regulatories, and then only that will go to the developers. So when the developers use AI, they will use it on a platform that was already approved by the regulatory and not just use AI as an open source. And I think this is a way that, at least in my learning, because we're afraid of AI making up things, use a background of knowledge that is already put inside, which is somewhat regulated and checked.
I agree with the regulation, but for rare disorders, I think this can be applied for like hypertension, diabetes, when you can do like masses. The problem with the rare disorders, patients usually one of a kind, bespoke. So there is something called art of medicine, and this is what we practice as the experts here. But about actually a comment on your presentation, which I forgot. So basically, the trials, so we have been doing sponsored trials for over a decade now, and honestly, that's my CR, clinical research supervisor, can sit when there is a presentation and we can tell when the protocol is not going to work. So the most common cause of protocols, the failure of protocols, they're written by people who don't know the disorder, who don't know the finesses, and who don't know what to look for, okay? So the reason why they are 40% amended before even they start, because of it's impossible either to recruit because they put such an exclusionary criteria which they're going to exclude so many people, or they are, like the steps is completely wrong, okay? So basically that is the problem. And the second problem is the protocols start for some reasons as let's just put this out and let's test this as we go, okay? So most protocols we deal with, they are amended like 20-something times, which means that they are not set up in the right way to start with, and then they navigate as they recruit the patients. So these are some of the problems, and I think the main reason is when the protocols start, there is a commercial interest at the beginning, and then the protocol try to be fit either, to manage some deadlines, this and that, around that commercial interest, not really around the patient. So I think this is the main problem why the protocols fail.
No, I totally agree, and we have the same experience. Yeah, sorry.
Okay, there's another question there.
Hello, I have like 2 questions. First is there any kind of tool or algorithm to detect false positive or false negative? Or second question is that in future, is there any possibility to make animal models with AI? Like is there any possibility to replace animal models with AI, just like you did with the human clinical trials?
I think we saw some nice examples on digital twins. So I think that can in the future replace animal models to a certain degree.
Just about the question of the positive and the negative, I think we'll never get to zero, and there is always a payment. So you can either choose to be more on the positive predictive value or the negative predictive value. I showed you on the cancer trials, so they decided they want to more work on including only eligible patients. So they were okay with finding patients less, but they wanted those that they find to be eligible for the studies. So it's really where you set your point and what you are agreeing to accept. So I don't believe that it will never be perfect, but it's really where you put your money on. And the more sensitive you are, then you will be less specific, and the more specific you are, you'll be less sensitive. That's how I see it. I don't know.
Actually, my question was about, to ask Dr. Ravi, like you saw some like false positives. So how to detect with AI those false positive or false negative from the accurate data? How did you, know? Because you already had a photo of your MRI, then you know that was false positive. But how did you detect that without knowing the actual result?
Oh, so it is based on knowing the actual result. So that the way that those trials were designed is they were looking at the output of the algorithm and then comparing that to the actual outcome. So that's how you know whether it was a true positive or a false positive. And as an example of that trial, other ones, for example, if you're determining whether the algorithm was able to actually accurately identify a lesion, for example, that would be in comparison with the human decision, which was considered the gold standard.
So that means it cannot give like 100% accuracy, right?
As of now, that's correct, yeah.
Okay. Thank you so much.
Mm-hmm.